Welcome to our virtual family council meeting. My name is Jamie Rose. I'm your virtual meeting coordinator. So let's review our confidentiality statement. Please refrain from using the name of your loved one. Do not name specific facilities. Please use a nursing home or the personal care home to present to the group. If you need specific assistance, please use the chat feature to state which county you are in, and we will get you connected to your assigned ombudsman. And just a reminder, these calls have public access and are designed for family members and friends of residents in long-term care facilities. So we'll quickly review our meeting agenda. We're going to get our virtual meeting tips from Jay. And then we're going to have our presentation on sexual expression in long-term care facilities. And then we'll review our upcoming meeting topics. We have some great topics lined up for everyone. Without further ado, I'll turn it over to Mr. Rotz for our virtual meeting tips.
Thank you, Jamie, and welcome everybody. You've all been placed on mute upon entry. We will open the lines in a bit so that you're able to share. If you would like to speak or have a question, please use the raise hand feature at the bottom of your screen. Once you raise your hand, we'll know to acknowledge you and unmute your line. If you hover your mouse near the bottom of your screen, you will see the Participants tab. That can be expanded if you'd like to see that. The chat features at the bottom of your screen as well. Once you maximize that, you will be able to send questions to the chat moderator or others during the call. Closed captioning is available during the call. To enable this feature, push on the CC icon again at the bottom of your screen and choose to enable closed captioning. If you need to step away, you can stop sharing your camera by clicking on the camera icon at the bottom of the screen. You can click on it again to start sharing your camera once again. And finally, any concerns or complaints can be directed to the State Ombudsman Office, me specifically, at 717-783-8975, or by email at ltc-ombudsman@pa.gov. And without any further ado, I yield the floor to our esteemed Dauphin County Ombudsman, Corey Hurley.
Hello, thanks, Jay. Tonight, our speaker has a real special topic for us. We're excited that she is willing to join us. So she is the Director of Social Services at the Hebrew Home at Riverdale in Bronx, New York. So please help us welcome Ann Weisbrod.
Hi, everybody. Thank you so much for having me. It's one of my favorite topics to really share because I really like to be able to, shed light on this topic in a really positive and informative kind of way. I've been doing this for 34 years. I've been at the same facility, and I've really seen the transformation of the acceptance of sexual expression in a long-term care facility really grow from really nothing to where we are now. And so I'm really very excited to share this with you. So I'm going to begin, and I want to start by saying that residents have many rights in a nursing home. We all know that they have the right to choose a healthcare advocate. We all know they have the right to make independent choices, to see medical records, all of these very tangible kind of things. But they also have a right to intimacy and sexual expression. Residents don't, our residents don't become less sexual just because they've aged and gone into a nursing home. Their sexuality is still a very basic human need that it doesn't go away. So we need to honor that expression. We need to help let them express that when we can. And we need to make sure that everyone is safe and that we are not, putting anyone in any kind of harm's way. But we need to give them that right. We need to be able to find them a private space if we can. It's not always available in a nursing home. And we need to allow our residents, many I know here have computers of their own, and we need to be able to let them have materials that are sexually explicit as long as they're utilizing them in their own rooms, in the privacy of their own rooms. So let's talk about sex in a nursing home for a minute. I think the question is, should sexuality be permitted in a nursing home? And the absolute answer is yes, by all means. What is the meaning of sex in an older adult doesn't necessarily mean what we think of as typical sex. It could mean just touching. It could mean companionship. It could mean being close, just holding hands. We've expanded the idea of what sexuality is because it's not the same for everyone as they get older. And the other question that people are always asking is, should residents with dementia be allowed to have intimate relationships? And that answer is yes also. And we'll get into that a little bit later as to how we navigate that, because it's a little less clear and not always quite as easy to determine. But without a doubt, residents with dementia have those same sexual needs and desires of anybody else, and sometimes even more so. So I like to say that living in a nursing home is more than just bedpans and call bells. The residents here don't just look for nurses to change them, to give them care. They look for people here who are going to help them honor their wishes and help them really, make sure that their rights are being honored. So we do not age out of being sexual. Sexuality also enhances relationships. It improves someone's quality of life. It makes people feel good about themselves. It often enhances emotional health. It also very often brings about, memories, wonderful memories of a life that they're no longer necessarily living, or may not even totally remember, but they may remember the good feelings that they had about their, loved ones, about their spouses that no longer are here. So having a level of ability to have some level of intimacy is really very good for one's emotional health also. And again, it's more about affection and affirmation and acts of necessarily typical sex as we, or sexual gratification as we like to think of it. So human intimate and emotional needs are expressed many, many different ways, as we know. It could be a simple touch on the shoulder, a hand on the face, a hug, and other times it is more. So we here at the nursing home have seen, the days where, people hid in their rooms and didn't want anyone to know what was going on, to now the ability to hold someone's hand in the hallway and to have some private time, and for us to acknowledge that that is their private time. So yes, we have to, absolutely must assist residents in developing the maximum level of independence that they can have and enabling them to function at their highest level of social and emotional well-being. And that also means allowing them to make choices and allowing them to make decisions on their own behalf if they can, and to express themselves in ways that they choose. So in 1995, I'm going to go back a little bit, the Hebrew home at Riverdale, where I've been, was the very first nursing home in the country to recognize resident rights and the need for a policy and procedure to deal with sexual expression. We had residents who wanted to be together. Nobody knew what to do. Everybody was, what do we do? Are they allowed? Are we going to let them? Everyone was, for lack of a better term, just freaking out that how do we handle this? So the Hebrew home really said, you know what, we need to look at this. These are adults. These are people who still have sexual needs, and we need to make a policy on how the staff is going to handle this in the most appropriate, professional, and dignified way. So we had to look at a lot of factors when we were doing this policy. We had to look, of course, at state requirements, because we all know that we have to follow those requirements. We had to look at expectations that we would be able to provide privacy. Now, we are not as fortunate as other facilities to have all private rooms. Many of our rooms are shared rooms. So we cannot always guarantee that we're going to have a private space, but the best we can possibly do, we will do. We have to very importantly, obviously, determine the capacity for the residents to consent to having a relationship, especially those with cognitive impairment. And again, we'll get into that in a little bit. We have to address staff training because the staff at this, certainly in 1995, were completely unprepared for how we were going to manage this and what were we going to do about that. So staff training was incredibly, incredibly important. And we have to make sure that we're protecting against any kind of sexual harassment and abuse by any residents toward each other. We had to make sure that everybody was safe. Safety obviously trumps everything. And we just had to make sure that we were working within all of those guidelines. And sure enough, we did come up with a policy. And ever since 1995, we've had a policy that we've changed over the course of time. We've updated it, we've modernized it a little bit, but we do have a policy. And one of the things we always remind our staff is that within the policy, we still have to look at every situation individually, because while you can have a policy, as you all know, for anything, there are certain times that situations need a little bit more of a look at, under a microscope. So we do have to look at every individual situation within itself. So this is sort of the easy part of the presentation, and that's the residents with capacity who are able to make their own decisions. We obviously want to help them. We want to honor them. We need to make sure they're safe. And again, we need to provide resident education. We have residents who've asked us for condoms, which we've provided, because we know that maybe pregnancy is not part of the concern, but sexually transmitted disease or anything is possible. We do provide condoms if we need to. Again, we look at a private space if possible. If we know we have a couple, so to speak, that live in two separate rooms that are shared, if we can give at least one of them a private room, we will try our best so that at least they do have some private space. Not always possible, but we will, work toward giving them privacy, even if they're in a shared room, in some way to honor their privacy, but make the space private for them when they would like. And most importantly, it's our responsibility to uphold the choices and the rights of cognitively impaired residents and work with families, because this whole area of sexual expression with those who have some cognitive challenges is a little bit frightening for most families, honestly. And it's where I think the staff get the most uncomfortable and maybe a little bit nervous. So, those with capacity, it's fairly easy. And I'm going to give you a little bit of I just want to tell you a little bit of a story that we had here a few years ago, just to show you to the extent that we went to try to honor this. This was still a little bit earlier on in our sexual expression days, I should say. It was a good, probably 7-8 years ago. And things were still evolving, and we had a couple who really wanted to share a room. They were not married, but they were a couple, and they both had capacity, and they wanted to be in the same room. So we had to figure out what to do. So they didn't want to live as roommates in the same room with one bed on one side of the room and one bed on the other. They wanted to live like they would at home they wanted a king size bed, which obviously we weren't able to provide, or a queen for that matter. But we actually did look into different size bedding, beds, but then you had the fire code and you had this and we had to look at, is the bed going to be too big so that the nurses can't come in and provide care? So there were so many things we wanted to look at, or we needed to look at, I should say, to try to help this couple live their best life and have the experiences that they want to have in privacy of their own room. So, and I must say that neither of these residents were ambulatory, to make life a little bit more challenging. Both were pretty much in wheelchairs, and both needed pretty much an extensive amount of assistance. So that only added a little bit of, challenge to our situation. So what we did is we were able to get 2 beds that were a tiny bit larger in size and put them together. Okay, now we have the question, we're putting the beds together. We have to secure them together. Oh, God forbid someone, the beds separate and someone falls. So we had to involve engineering now in making sure we could get the beds together. And all this time we're struggling with, the privacy of these residents too, because now you're involving so many people in this attempt to get them into a room together. And it's clear that you're trying to let a couple have their own private space, and you're involving all these people. So anyway, the bottom line is we were successful. We involved the couple in the decisions. We involved them in deciding whether they really wanted the beds together or not. We really tried to include them while explaining to them the safety concerns we had and the limitations we had with staff, care, etc. And they worked with us. We got the beds together and they had a very nice relationship. And lo and behold, about 2.5 weeks later, they broke up. So we had to undo everything we did because now the woman was telling us that she did not want to be in the same room. She felt uncomfortable. And we obviously immediately removed her from the room and turned the room back into a double room. But the reason I'm showing you this case study is that I just want to show you what sometimes has to be done or even considered just to try to accommodate two people who really have cognitive abilities. You may not go to quite that extent, and I can't say that I remember another case quite that involved since then, but it's just going to the point of honoring the wishes of two very learn-oriented people. And by the way, their families were very supportive of this because a lot of people wonder, what do you do about that? And as long as the residents are alert and oriented, it's their decisions, not their families, but their families were aware and were very supportive. So, so that's kind of easy when it comes to the alert and oriented. So now we talk about those with cognitive impairment. And that's, of course, as I said, when it does become a little more challenging, a little bit harder for families and a little bit harder for staff. Because everyone's concern is that everyone be safe, that their, safety not be compromised. And, you're not always sure. People get nervous if, you have people who can't necessarily express themselves. But nevertheless, with those with cognitive impairments, they too have a need for human contact. It doesn't, just because they have a level of impaired cognition, that need for contact transcends that. Again, that human contact may really calm them down. It may be almost a non-pharmacological approach, to certain agitated behaviors if they have someone that they feel comfortable with, and to sit for even a half an hour and hold their hands instead of getting agitated and being restless is a wonderful thing. It's very important that there be a team-based approach, particularly with cognitively impaired residents, because no one team person, and when I say team, I'm talking, of course, about the nurse, the doctor, the social worker, the dietitian, the the activities person, and even, physical occupational therapy, anyone who's involved with that resident. There needs to be a team discussion as to the level of ability. We have to make sure that everyone is non-judgmental about what we're discussing. We can't have staff who have personal bias, which we know is very hard to, combat, because people do come in with their own very preconceived ideas. And they really have to be, as a team, assess the residents' level of capacity to decide whether this is going to be a benefit to them, harm them, or cause them any distress. And those are really the three factors we really look at with those with cognitive impairment. I would say it's benefit, harm, or distress. So as a team, we would discuss that when we observe two residents, interacting with each other and seeming to want to have more of a relationship with each other than just sitting in the same room. And again, these relationships could really bring about wonderful memories that they may not be able to conjure up themselves, but just the touch of someone's hands may remind them that they once felt that nice touch of their spouse or, partner's hands. And this is reminding them of that. So it really could be, a wonderful way to deal with their emotional needs as well. So when we talk about consent, it often really arises when one or both of the residents has diminished cognitive capacity. It doesn't necessarily mean both have diminished, but even if just one has diminished capacity, we really have to talk about consent. Cognitive impairment doesn't, as I said, eliminate the ability to recognize the desire for sexual intimacy or any kind of intimacy, or even just pursuing a relationship with somebody else. We have residents on our memory care floors that have really, found each other, and it really is sitting and holding hands. But for them, they're pursuing that meaningful relationship. There may not even be conversation, but just that hands holding alone. And when we look at, again, the benefit, the harm, or the distress, what we see is pure benefit. And, that's something that we would be discussing as a team. I just want to, many of you may remember there was Sandra Day O'Connor, the Supreme Court Justice. I don't know if everyone knows the story, but her husband was in a nursing home with fairly significant dementia. And he forgot who she was. He didn't remember he had a wife. And she would still come visit very regularly, but he really didn't know who she was. And the staff told her that he had developed a relationship with another woman on the floor. And when I say relationship, I mean by hands holding, cuddling, maybe a little bit of kissing. And they were afraid to tell her, but they felt they obviously needed to tell her, especially since she came to visit and she may very much stumble upon that. And this is something where family education is really, really important, especially with cognitive impairment. She had the attitude, which I just really admire, that while this is still her husband's, in body, unfortunately, he had no memory of who she was. And her feeling was, if he didn't know who she was and this lady made him happy and made him feel good, then she was in complete support of it. And it didn't mean she didn't come to visit, but she accepted this new normal for her husband's and saw the benefit and really was able to accept it. And then we have, on the other hand, we have families where we had a gentleman who had a wife in the community, but he developed a relationship here and she just couldn't accept it at all. And we'll talk about this in a little bit, but she, despite the fact that it was beneficial to him, at least in the team's opinion, it was not beneficial to her. And when she would come to visit, it would create such distress for her that it would then translate to distress for him. So ultimately, and she was his healthcare proxy, so we did ultimately have to move him off of the floor that this other woman lived on, because unfortunately it was just creating too much of a problem for both of them, and it was no longer causing those benefits. So, you have two sides of a very difficult coin, and, it's very hard for families and very hard for staff sometimes. So what happens if a resident cannot verbally consent? If they can't say to someone, yes, hold my hand, or yes, does that mean they can't express themselves? And again, the answer is going to be no. But that's where the care team is really going to have to come in and really assess what's going on if that resident's not verbally able to articulate their needs. In those situations, privacy may not be the way to go if we don't know and that resident can't speak out, but it may mean that we give them the opportunity to be with somebody in a common space, even if it's off a little bit on, to the side. But we have to be very careful. And those are where you really have to, again, the team approach of looking to see, yes, it may be beneficial, but to what degree? What do we have to do to keep it safe and to keep harm, out of the picture? And we have to always, and assess for distress. So, we have our sexual expression as part of our person-centered, patient-centered care. Because really what this is all about is ultimately the resident, the patient, however you define them, and what is best for them, not what is best for the whole floor, but what is best for each individual resident. And again, the interdisciplinary team has to make a clinical determination. They have to really weigh the signs of distress, risks, benefits associated with this sexual expression. And then we really can determine whether or not there's mutual consent. Often, really, we do have to involve the family when it comes to those diminished capacity or cognitive impairment, because the family usually are either the healthcare proxy or the surrogate. And in this case, if we're not 100% sure that the resident's going to be able to articulate, we do involve the family. But there's a lot of family education that goes into this. And when I say that, I mean, we want the family to understand what we're seeing, not just, hey, is it okay if your mom hangs out with Joe today or Mary today and they hold hands and maybe kiss a little? That's not the approach. The approach is really, hey, we're seeing your mom or dad developing a very wonderful relationship with somebody, and we want to include you in this planning process of how we can move forward with this so that it's beneficial. And, at any sign that it's no longer that, we would stop and have to look at it differently. But we'd like to include you in the process. So the involvement of family is going to be, often very necessary. So, sorry about that. So, again, the non-consensual sexual expression, what do we do? So we have one resident that is interested, one resident that isn't. That's somewhat clear cut. We see some distress, or we see somebody pushing someone away and another resident is perseverating. And we've certainly had this on many occasions. We then have to obviously separate those residents and if necessary, relocate one to another unit. And involve the family and let them know exactly what's going on. And rarely will a family, argue about moving their relative if it means their safety and, lack of distress and, safety. So we want to allow all the sexual expression, and we want to be able to make sure it's safe and make sure that we assess all situations. And by the way, I don't want to say we don't sometimes get involved even with residents who are alert and oriented, in the sense that there too, if we see something that seems, to be distressful to one of them and they're not speaking up, we will take that resident aside, that social worker will, we have psychology services, and we will try to make sure that that resident has a voice to speak out as to whether or not they're, interested. Because sometimes, some things don't change from when you're younger. You feel pressured. You don't want to say no. We have that here too. And so I just, I do want to say that we do often get involved in those situations as well. So let's talk about barriers, because it's all well and good to have all of this policy and procedure and wanting to have residents have the ability to express these rights. But there are barriers that we have to deal with, which sometimes make it very difficult to ensure that these rights are happening. Sometimes the most obvious is whether or not we have a private room, or whether or not we have to, somehow work out something within a common area for, residents who just want to hold hands, who, we've had, and I'm sure other people work in nursing homes or, any kind of residential facilities have seen where, there are residents who often display, sexual, acts in a public area. And obviously we have to, stop that. But the ability to try to find a private area is something that we do try our best with, but not always successfully. So the two biggest barriers I honestly feel we have are the staff and the families. And when I say staff, I'm not pinpointing any one staff, but let's face it, everybody comes in with their own ideas of what old people should be like, what nursing home residents should be like. And, you have plenty of people who think you come into a nursing home and that's it. It's, they have cultural beliefs, religious beliefs, their own personal beliefs. But we need to remember that we need to show dignity, respect, and be consistent when we're, facing these situations that come up when it comes to sexual expression and intimacy. And I always say when I'm, talking to the staff, please, it will happen. You will ultimately have a situation with two residents in some way that this is going to happen. So we need to be prepared. You can't get caught unprepared. You have to know that this is likely going to happen. We have to teach staff that they're going to have to, on dementia floors in particular, possibly do extra rounding and extra eyes on potential situations that we have to monitor to make sure, again, that they remain safe. We have to, as an institution, have a commitment that everyone is going to try to honor these wishes as best as we possibly can. So the fear of reaction. So what are some of the things you can think about? Again, it doesn't change much from when you're younger in some ways than, and it goes into this population. There's the fear of being embarrassed. And I'm now talking both those with capacity and even those without. But there's sometimes the barrier of two people who like each other, who want to be together in some way, but they're embarrassed. They don't want people to know. They don't want staff to know. They don't want their families to know. They don't want other residents to know. And that's a barrier because they could be having a quality of life that's much different if they didn't feel that they were going to be, ostracized in any way. So it's very much the job of the nursing home staff, everybody, to really help them, express that and help them to figure out a way to get past that if that's what they want to, if they want to, and really work with them in a really, positive kind of way. When we think of these, when you think of residents having sex or whatever you want to say in a nursing home, you almost associate it with a negative behavior, or you tend to, laugh or think, oh my God, that's ridiculous. So the focus has to be on turning this into a positive, emotional quality of life, so many positives. And that's something we really have to look at in the whole picture. What will people think of me if I'm have a boyfriend, a girlfriend, whatever it is. The next barrier is not just the residents' own fear of expressing their interest, but oh my God, the family. So families run a whole gamut of responses. And it's easy for me to sit here and say how we should react, and then I put myself in my own position and think about my own mother. And, we all are normal human beings. But here in the nursing home, we really need to look at the family's reaction. We hear, my mother doesn't do that. You have to be kidding me. You have no idea what you're talking about. Or my mother can't do that. What are you talking about? She's in a wheelchair. I can barely get her to hold a cup of juice. She can't possibly do that. So, and, amongst other things, for example, what will the staff think of me as a daughter if I say it's okay for my mother to be in this relationship? Are they going to think I don't care? Are they going to think I'm not interested? And let's face it, no child generally, no matter what age you are, really thinks of their parents as sexual beings. Nobody pictures that, nobody wants to picture that, and it doesn't change when the family member is in a nursing home. Children still feel that way. And then some of them even say, oh my God, I put my mother in a nursing home. And now this is what's happening. I can't believe it. Did I make a mistake? Should I have just left her at home? Well, what's happening here? And it's most of it, all of these comments are not because they don't love their parent or they don't want the best for their parent, but this is just uncharted territory for most people. And it's scary for them. And I don't, it doesn't matter whether their parent has capacity or doesn't have capacity. It is very much uncharted territory. So one of the most important things that we feel is necessary is a really good way of educating families. At the time of a resident is admitted, get a good history from the family and or the residents. Find out if they, if they were married. Obviously, you're going to find out if they're married, but try to get a picture of what they were like, so that if something, if you need to say, well, hey, you did say your mother really loved to go out. She was a real, social person. And this doesn't necessarily stray from that. You want to educate families and get as good of a history as you can so that you can work with the families. You want to have family meetings. You want to have care team meetings with the families and include, as I said before, very much include them, particularly on a dementia floor, in the planning, in the discussion of, how are we going to proceed with this so that their quality of life is enhanced and yet they're safe. The more you involve the family, the less secretive it becomes and the less of a stigma it becomes. It's very important to include the families. Communication is one of, a very important tool. So I know there was a question that just came up, but I sort of missed it. So I guess we can go back to it afterwards. So another barrier is, for residents to just get together are social opportunities. Hopefully there are activities within a nursing home. You have, a multitude of activities, but we've done what we've done here is we've had activities that sort of mimic more of an opportunity to meet people in a social setting versus just, bingo or a concert, things like that. So we've had different kind of, I don't remember exactly what we called them, but like a prom situation where we had champagne and we did it in May at the time that, graduations are usually held. And, they just got all dressed up. It was just a wonderful opportunity. The funny thing is that we had people put their name in a basket to be a prom king and queen. And the two people that were picked randomly ended up actually forming a relationship, and they've been in a relationship here now for over 5 years. So it's, it's just some fun activities that give residents a chance. We are in a very large facility with almost 600 beds. And from one end to the other, you have no idea who's living anywhere. So these opportunities are a good chance for people to get to meet each other. We also started a program, I would say about 6 years ago. It was really a takeoff on, J date. We called it G date, actually, for grandma, grandpa. And it was not online, but what we did is we had a questionnaire we developed, and it was obviously only for people who were interested. And, either they expressed to the social worker that they were looking or interested in meeting somebody, or we thought they might be interested, based on the type of personality they had, we might have had that discussion with them. And we developed a questionnaire where we asked them just, like 10 or 11 very simple questions about their likes, their dislikes, preferences of gender, preferences of a long-term relationship versus just getting to know someone, what they like to do, their favorite hobbies, etc. And everyone who was interested in being part of this program filled it out. And then what the social work staff would do is about once a month or whenever they had enough applications to go through, they would match people up kind of randomly, but not randomly. We tried to match up as many of the attributes of each other that we thought would work well together. And we set them up on a blind date. We have a cafeteria, a little restaurant. We used it during a time when nobody else was there. We set a table, we had flowers, we put a tablecloth, and we gave them coffee and cake and, a little dessert, and we let them sit for a while, unattended, unsupervised, as adults, and they got to know each other. And while I will say that so far the program has been so much fun for the residents and so much fun for us, and we haven't had any necessarily, I would say, long-term relations come out of it, but we've had some wonderful friendships come out of it. And quite honestly, when you're talking about, we say sexual expression and intimacy in a nursing home, sometimes even just friendships can be very intimate, and that's really enabling our residents to have that, which they may not have been able to have on their own. And, even just making a best friend, someone to share their thoughts and experiences with. So for us, it's been, a really wonderful program. So the next barrier that often is, to me, just sometimes as hard as the families, is the staff. So again, we do a lot of training with our staff. We, besides the fact that we have annual training that everybody has to take based on state requirements, we also do trainings separate and apart just on this policy and how to go about upholding this right. And I want to say it's not just for the clinical team, nurses, social workers, doctors, dietitians, activities, therapists. We also include housekeepers. We include the maintenance men. We include, the kitchen, the people in the kitchen. It's very important to include everybody in the training because everybody works on a floor and everybody sees things and everybody has different relations. We have some housekeepers here who have unbelievably amazing relationships with some of our residents because they're in their rooms every day cleaning their rooms, and they talk to them, and we want them to be prepared in case a conversation comes up, to at least, even if they can't have an in-depth conversation about it, to at least not be afraid of it and know what to do with it. So it's very important to train all of your staff in this. Again, like I said, housekeeping, engineering, and we have to be very careful to make sure we train them in what we consider to be a healthy and safe sexual level of expression, or an unhealthy, unsafe situation. That really obviously is the most important, and that is what staff often struggle with, because particularly with those without capacity or those with dementia, the fear that maybe they're not keeping their residents safe is always on the back of their mind. So that's why the team approach is so important. Nobody's working in a vacuum. We're all working together to help make the right decisions and honor the decisions of our residents. And for the staff, again, if they're uncomfortable or if they don't know what to do, we really encourage them to seek out supervisors, they can come to me, they come to other staff members who work on this. And, it is very successful, but there's constant reminders, because you can train everybody, but then when the moment happens, people's own biases, kick in, and sometimes they need to just be reminded of, what they need to do. And what we found is really people have been very, very supportive. They may need some help, but they're very supportive. The other thing that the Hebrew Home has done, and I have to, imagine that other facilities as well, first of all, we now have baby boomers coming in. So this is going to be that much more of a topic, as people who are younger, a little bit younger, might be coming to nursing homes now. We have seen a bit of particularly in our rehab populations, a younger group. And we do have some younger people, and when I say younger, not much below in their 60s, maybe a few below that if they have dementia, but we have to be aware that this is going to become more of a topic. And we've also expanded our training to include all relationships, male, female, male, male, female, female, all any type of relationship that we want to encourage, and again, as long as it's healthy and safe. So we actually have an LGBTQ group here that is co-led by a social worker and an activity therapist. And we even teach, in that group, it's for those who identify and those who are allies. And it's a wonderful opportunity for those who identify to feel safe in an environment, and those who are allies to learn more about other ways of life that they were not, especially the older population, not that familiar with. So we are, the diversity and sensitivity training is extremely important and will become that much more important as time goes on. So I think I'm almost done, and I certainly would love to take questions. I think my last two comments is, again, all residents have the same rights. Cognitive impairment versus cognitively intact. Rights are the same. You take out a resident rights handbook, it doesn't distinguish between the two. And this right is right in there with that. Again, the only difference is how we go about enabling it to happen and acknowledging and assessing each situation. And the last thing is what I tell the staff. It's not about what you think. It's not, let me start again, I'm sorry. It's about what you actually see, not what you think you see. Because again, if a staff person walks into a room and they see two residents hugging, but their mind goes to something far different, that's not what they're seeing. And that's not what they should be reacting to, or, it's what you see in the moment. And that's a very important lesson that we try to teach our staff. So I think with that, I've pretty much concluded. And I'm happy to take questions.
We had one question in the chat. Jeannie writes, what about situations where a resident becomes fixated on a staff member? Resident may use inappropriate language or behaviors, and this behavior is not reciprocated by the staff.
So that's a great question, and that's definitely has happened. It's happened both actually in our cognitively intact population, and it's happened in our cognitively impaired population. Obviously, a lot of training, making sure that staff member knows how to react appropriately is the most important thing. And depending on what that behavior is of that resident, I would say that you would either want to, look at, whether that person has dementia. You'd either want to look at the issue of whether or not they're fixated particularly on that one staff member, or they're going to, if we move them, are they going to, this is something we always think about. If we move them, is it just going to be another staff member that becomes a focus of fixation, or another resident? So in that sense, we will bring in, and I should have mentioned this earlier, we do have psychologists and psychiatrists that are, available to us as part of our consultation group. And when we're not sure how to handle a situation similar, could be something like that, what is it that we need to do for the resident to stop, in this case, the behavior, and I use it more in a non-positive type term. Do we need to get them engaged in other activities? Do we need to move them off that particular floor? Do we need to move the staff person off that floor? You really need to assess that situation. Sometimes when the person has capacity, that's almost a little bit harder, because with dementia, you can almost attribute it to the dementia and you can deal with it in that way. But with capacity, you're dealing with someone who's making a choice very cognitively that they know it may not be right. And that's something you have to deal with, one-on-one. That may involve supervisors speaking with that resident, psychiatrists speaking with them, psychologists, whatever you need to do to try to get that resident to stop, or if necessary, move the resident off the floor. We have also hospitalized, if you're talking about behaviors that become physically violent in any way, then we have to send someone out to the hospital.
And then another question from Jeannie, do you have a staff training program that can be shared?
We are actually in the process of just finishing up our newest one. So yes, as soon as we finish that one up, I would be happy to share it if someone tells me how to, where to send it.
That's all the questions we have in the chat right now. Feel free to write any questions you may have in the chat if you'd like.
So the question, I'm sorry.
Yeah, sorry. One other question from Carol. What about a capable resident preying on an incapable resident who isn't interested?
So again, that's where the team really has to come in. We most likely, if when using the word praying, we're going to have to move somebody if they're not going to stop and understand what they're doing and recognize that is not going to happen and that it's not safe. If necessary, and if it's someone on their floor, we will have to separate. If it's someone within the home, and we think that there's any danger, always that if someone's a danger to themselves or others, that's a reason to hospitalize somebody. So it depends on, it's a very broad question, a great question, a broad one. It depends how much you can reason with that person who is the one who's trying to get that attention and really get them to stop. But you have to use all the staff at your disposal that you feel will, we bring in the psychologist, psychiatrist, the doctor. This is sometimes a medical concern if somebody's doing something, and sometimes there's something medically wrong that all of a sudden their personality is, like a UTI, can change someone's personality, and maybe that's causing them to become hypersexual, or, there's a medical reason for something. So there's so many different ways to look at that, but it definitely has to be addressed.
I don't see any other questions right now in the chat. Thank you though, Anne.
Yes, thank you very much. Don't see any hands either at this time. But if anybody is like me and they think of a question later for Anne, just send it to our email and we will get it over to Anne and hopefully get you an answer. But thank you so much for presenting. Very
Thank you
good
for having
information.
me. Thank you so much.
That was fantastic. And we will have the video up. If anybody had to step away and missed any of it, it'll be up on the Facebook page, hopefully by this evening. All right. And as I said, don't forget to join our chat group associated with our Facebook page. We have a chat area for just the family members that is a separate area from our main page. All right, so some of our upcoming meeting topics. So on March 8th, we're going to do a call to action meeting. We have a couple of bills that are that need our attention. So the Older Adult Protective Services Act, criminal background checks, that is a bill. We're going to hear from Carolyn Green. She's going to explain that a little bit to us and see what that bill entails. Actually is adding some additional criminal background checks, and then on a yearly basis instead of a one and done as it currently stands. And then we're going to explain a little bit more about our Social Security income bed crisis. So we are losing our SSI beds at a rapid rate here in Pennsylvania. So we have a call to action for everyone, and we can teach you some of our advocacy tips for that, because that is part of the governor's budget, and we're really hoping to see that go through. So March 22nd, we're going to actually have a hospice agency come and discuss hospice services and long-term care. And then in April, on the 5th, we're going to have filing a complaint and who to call. So when would be the best time to call a licensing agent, protective services, or an ombudsman? So we're going to break that down for everyone. And as always, thank you so much for attending our meeting. If you have any specific concerns or complaints, You can send those over to Jay at the State Ombudsman Office, 717-783-8975, or shoot them an email at ltc-ombudsman@pa.gov, or over at the Facebook page, then you'll get a hold of me, Jamie Rose. So thank you, everyone. Let's try to stay dry, stay warm. Great having you tonight, and take care.